All right, so this is going to be pretty quick, and I want to hear what people think. Actually, I think this has been around for about 10 years now, but when I was told to put this talk together, actually I'm covering for Naveen Kapoor, who couldn't make it. The real question for me was, wow, it's been a while since we did this interventional heart failure thing. So I went back and tried to look at where this came up. And I talked to my friend Dan Burkhoff, who many of you guys know. I actually called him and I said, look, he calls me, I texted him, he texted me right back. He thought it was a very important question. The question I had for him is that when did we first start hearing about interventional heart failure? And he loved that I was talking about it. We're actually thinking about writing a paper on this topic, reviewing it. But I went back, and this is from the clinics that I wrote in 2007. And I was trying to figure out, this might be sort of the earliest concept of interventional therapy for heart failure. I think at the time, obviously I trained at Penn. I wrote a lot about the folks that I met there, including Mariel Jessup, who was a big inspiration for me in heart failure. I also learned last night that Dharam was an intern when I was a fellow. I didn't know that. He was, spying on me back then. But, after I was thinking about doing heart failure, then I ended up doing interventional, and then I ended up putting the two together, essentially, that the things I liked about heart failure were the interventions, and the things I liked about interventional was the heart failure. And so my career has evolved towards hypertrophic cardiomyopathy and cardiogenic shock, which is, obvious from there. So we put this thing together, which is basically a tour de force on all the interventions we had at the time that dealt with heart failure, which is mostly revascularization and a very fledgling field conceptually of assist devices, mostly balloon pumps at the time. This is kind of pre-Impella, as well as the burgeoning field of structural heart disease. So then I looked, and the only article I could find after that was this article, and I don't know these people, but they did a brilliant job in a two-part series, and I think they probably did coin the term interventional heart failure when you put the three words together. They had two articles that went through all of the areas that interventions could work in heart failure, and this is what they came up with. They went through the 10 arms of interventional heart failure, from palliative care to self-care, fluid removal, which we're not doing too much about today, but it's something we can talk about, transplantation like stem cells, mechanical assist devices, which at the time was not much, but mostly implantable. You can see all of this, continuous inotropic support, electrical therapies like ICDs and CRT, those were available. Treatment of valvular disease, they didn't even talk about TAVR and this stuff because we didn't have TAVR or TMVR. And then treatment of coronary disease, which was fairly robust. So I put together this blog. I used to write a blog. For about 5 years, I wrote a blog, just my own thoughts about things from 2007, 2013, until I had no further, no further ideas. And at the time, I was doing a blog every month, and it was very hard. So I will never do it again. But one of the topics I did in 2011 was interventional heart failure, has its time come? That's 10 years ago, 11 years ago now. I talked about what is interventional heart failure, giving credit to a lot of my mentors at Mount Sinai and then Penn. And so I pitched to Sky this idea that heart failure is now a global epidemic. Most of what we do involves heart failure, either treating it or preventing it. IC docs should reacquaint themselves with the lost art of advanced hemodynamics. Heart failure docs should avail themselves more of the potential treatments IC can provide. In other words, I felt that a lot of heart failure docs, no offense, Peter, is that they would go from meds to transplant. There's like a whole desert oasis in between that they really didn't think about, and we should put ourselves in there because it's better for the patient. And ideally, there should be mixing now and eventually combined training later of interventional cardiology and heart failure, so I brought it to Sky. And I pitched this. I'm showing this because Dharam's doing a lot in Sky too. I pitched this to Sky. This was my idea to form a working group in interventional heart failure. This is from 2011. I'm glad I have all my documents, even though I changed hospitals a couple times. I pitched it. Mort Kern was very involved, John LaSala, and Bill O'Neill. So I've been working with Bill O'Neill for a long, long time. So I pitched it to them. Norm Linsky was the director, executive director, and I went through what is this idea. And we formed a working group. And for about 5 years, we had this working group. And a working group, by definition, can have people that are not just interventional cardiologists. So we put in heart failure people, imaging people. It was sort of the earliest days of ever having anybody who's not an interventional cardiologist in SCAI. And so created by Jim Goldstein, who's at Beaumont and does a lot of heart failure there. We put together sessions, bidirectional sessions between Sky and HFSA, hemodynamics and treatments we're focusing on, and treating complex patients, a lot of complex case presentations. Publications and presentations, we built this into the ELM program. In the first class of ELM was a young guy named Naveen Kapoor, and he has obviously blossomed in this field as well, and so I was his mentor formally for the program 10 years ago. And then fellowships, and then evolution of the initiative, that's how it's kind of gone, to Sky Shock, to the Cardiogenic Shock Working Group, to randomized trials, high-risk PCI, moving on to CHIP and CTO and whatnot. So a couple publications that came out of it was one, this big publication in 2015, which was how to use mechanical support. Myself and Srihari ran this one. This got a lot of citations because at the time, no one knew where to use these and had any consensus on what to do with it. Oh, and look who came just now is Paul Srihari. So Paul Srihari and I put together this document here. I don't know what Paul's doing here, but he's here. He showed up. So Paul put together this document, which I think is a brilliant document. The idea here was that if we're going to get people to look at heart failure, interventionalists have to understand heart failure, which means we need to have in every lab at least one or two people who can do a really meticulous hemodynamic evaluation. And so we put together this document to go through every situation in the cath lab and how to do a meticulous hemodynamic evaluation. And this has, I think, gotten a lot of press as well. So what is the fundamental mentality of an IHF doc? Number one, be the go-to person for invasive hemodynamics. That's first and foremost. It's a cognitive field. Comprehensive, expert technique, nuanced interpretation. Ability to dissect out various contributors to the totality of the heart failure state based on hemodynamics alone. Utilize medications then to optimize based on GDMT, acutely and longer term, and then provide for and choose between all interventional EP therapies to incrementally improve the heart failure state, starting with those with the largest benefit to risk ratios. So that's interventional heart failure. How do you choose, do the least harm with the most benefit, and then keep on going, repeat until the patient is better or it's futile. So what about training? This has been coming up lately in the past 10 years. You can either do sequential fellowships in interventional cardiology and heart failure in either order, or you can do a combined fellowship, such as Naveen is doing at Tufts, and graduate physicians with both heart failure and interventional cardiology privileges. So that allows you to manage complicated heart failure patients, hands-on hemodynamics evaluation, and select interventional treatments, including coronary, structural, and MCS. You may participate in transplant team depending on training, and you may participate in STEMI call depending on training, but obviously it's a work in progress and depends on your hospital and privileging, which can be complicated and quite siloed. So ACC has caught on to this and recently put on this, on their website, training finally in interventional heart failure. I thought this was brilliant. So everybody's catching on, and I will tell you about a 15-year process here. The number of naysayers thinking that we always have to stay in these silos is enormous. And I want to give credit to those few fellows who have gone through this pathway formally, younger than me, where we didn't have this, to go through this and really be that kind of physician. So what's so unique about IHF? IHF is the first quote-unquote real attempt to move past procedure-based fellowship training to more disease-based. We've always had heart failure training that is a disease-based, but really, as I mentioned, historically it's been more about transplant and implantable VADs versus medical therapy. Lots of resistance to the concept early on, but in theory, a quote-unquote super soldier should be more effective and efficient than a team of experts. So heart team is wonderful, but if you have really super people on that team who know all about it, that would be even better. And so thank you. That is the mentality of the heart failure specialist, also known as the super soldier serum explained. That's what Paul looks like. Thank you.
Can I, since we've got a few minutes here, I want to take the opportunity to ask you a question. You know, there's clearly a need for people who have understanding and appreciation of both disciplines, and there's so much crossover. One of the things that always comes up in terms of training and education is, as you know, it's a long pathway regardless. Do you think, would it make sense, should we be pitching to the, ABIM, et cetera, instead of 3 years of general cardiology, a year of interventional, a year of heart failure, sort of an abbreviated 2 years of general and then 1 year of each? I mean, should we be also looking at the training pathways in a sense that this is not adding yet another year of training to people that are trying to start families and all these kinds of things that are pressures that are very real?
Yeah, I think it's a great point. It all depends on what you think you want to do in IHF. If you want to do mechanical support and coronary interventions, you can probably do all of that. But if you want to do the structural procedures and other select procedures that can impact the heart failure state, you're going to need more time. I trained, even 20 years ago, when I trained, my third year was all intervention. So a lot of places do that. I don't understand why ACC and Sky haven't done that yet. And I'm going to be more involved at a very high level at Sky very soon, so we can try to push that cardiology should be able to do 2 years and then move into what you want to do, if it's interventional heart failure and structural. The challenge will be volume. So I think a lot of places want to do this. You need to, the fellows, the main problem they have is not just having the right mentors, but having the appropriate volume and cross-section of volume to really train in it. But I think it still starts with the hemodynamics. I think even though most of those most of those, when you move on to interventional to structural, I still think a lot of hemodynamics is lost. So I think the big move is to earlier in first and second year master the hemodynamics for people, and then you can just master the technical aspects of the field later on.
And then just sort of a follow-up on that one thing I think is a logistical challenge, or can be, is for someone who's in practice, depending on the size and the structure of your practice, heart failure call can be very demanding, and that we're often taking care of the mechanical support patients and critically ill patients. We manage the ECMO at our hospital, for example. And STEMI call can also be very demanding. And so how do you balance, are you in one call pool, the other? That seems to me to be another challenge.
Yeah, so it's interesting because I do a little bit of both. So I am an interventionalist, and I do the STEMI call pool, but on the weekends, I cover the whole heart failure service, including the transplant. So I'm in the heart failure pool for call, but I'm also in the interventional, but we double dip. So when I'm doing critical care, I'm running the CCU, rounding all the heart failure patients, and doing the STEMIs. But it's concentrated, but in a way, I don't mind it because I like that stuff. I like taking care of those patients. So, work is hard, but if you're doing exactly what you like to do, it's not so bad. So I think that's how we do it.
Any other comments from the panel or questions from the audience? Mike, too.
Ari, that was great. It was really nice to see sort of your vision and, a lot of the pioneering work that you've done in this. I think another movement sort of that has gained a lot of traction recently is this phenotype of a critical care cardiologist. And I think there's probably a lot of intersection between, what you described and what the roles for that. Those are usually non-interventionalists. So what do you think? How do you see that sort of melding together?
I'm very pro critical care cardiology. I think that every hospital I've been in, we've had different people interested in critical care around in the CCU. So in our hospital, we have 2 dedicated critical care folk, and then we have all the interventional cardiologists and all the heart failure people. And it's very clear that the philosophy of how you treat is a little bit different each time that someone is rounding. So I think that we do need a lot of critical care cardiologists, and that'll allow the heart failure and the interventionalists to step back and be more sort of team-based management of all these patients and provide the consults in the CCU for those patients, but then also really, be more disease-based and let the critical care physicians have a standardized approach that incorporates all of these things. They should probably not be the interventional heart failure person because they're going to be ideally staying in the unit as much as possible, micromanaging, which is something that we didn't really do well. But I think going forward, that'll be a pillar that'll allow interventional heart failure to really, prosper outside.
Any questions or comments from the audience? All right. Well, next I'll briefly introduce Dr. Kumbhani will be our next speaker, looking at the valve and the ventricle. So come on up.
Thank you so much, moderators, panelists, and everyone here. So really an honor to talk about deciding ventricle versus valve for treatment. Do you mind if I point? That's okay. So I have no disclosures to this talk. So, this is sort of the classic, chicken and egg question that comes up every single time. You have a patient with severe valve disease, and they also have a sick ventricle. And then you're kind of always scratching your head. Is it the valve? Is it the ventricle? Which one came first? Which one's now kind of the driving force? And a lot of times it may be both. And so, I'm going to try to talk about this a little bit differently for aortic valve disease and mitral valve disease, because I think there are some nuances to both of them that may be relevant. So, looking at aortic valve disease, the 2020 valve guidelines have a 3-tiered classification for symptomatic severe aortic stenosis. D1, as you know, is sort of symptomatic high-gradient aortic stenosis with normal ejection fraction. D2 is sort of low-flow, low-gradient aortic stenosis with reduced ejection fraction. And then D3 is low-flow, low-gradient AS with preserved ejection fraction, also known as paradoxical low-flow, low-gradient AS. And so they are all three sort of, in valve clinic, you certainly see all 3 types of patients. Now, one thing about low-flow, low-gradient AS, particularly the D2 phenotype, is that it is estimated that about 35%, or roughly about a third of patients with severe AS, will have this phenotype defined as an EF less than or equal to 50%, low flow defined as a stroke volume index of less than 35, and then a low gradient of less than 40. Now, of these, it appears that low flow is probably the strongest predictor of long-term outcomes, particular mortality. And in the past, it used to be a common reason for not referring these patients for aortic valve replacement. Now, when faced with a patient with this condition, sort of the three questions that come to mind: is it truly severe AS? Are the symptoms from the AS or from the ventricle? And is the LV systolic dysfunction in this patient actually caused by the aortic stenosis? So this is sort of a common pathway that most are familiar with. But when faced with sort of this scenario where you have a low gradient, low EF, gradients sort of less than 40, but the valve area is less than 1, perhaps the first test in this, particularly for this D2 phenotype, is a dobutamine stress. And historically, the first thing that people would look for would be the contractile reserve, which was defined as a stroke volume index, a stroke volume increase of at least 20%. And so that was the first thing. And then once you had a response from the dobutamine, then you were able to look at the gradient. So if your gradient went up and the valve area stayed the same or went lower, then that was indicative of true severe aortic stenosis. But as the gradient actually stayed the same or got lower, once the ventricle was able to beat better, then the valve area typically would get higher, and then that was pseudo-severe aortic stenosis. You also have a lot of people who probably don't have an adequate contractile reserve, and in those patients, this test may not be as helpful. In those patients, and also I'll talk, there's an increasing role for a calcium score, and so Marie Clavel and colleagues have done a lot of the pioneering work in this field, and they have demonstrated that for men, a calcium score greater than 2065, and for women, a calcium score greater than 1275 is sort of indicative of severe aortic stenosis. And in fact, this calcium score has now also been adopted in the guidelines. So in the ESC guidelines, they have sort of rounded these. So for men, 2,000, and for women, 1,200, as being predictive of having severe aortic stenosis. And they also go to great pains to discuss that this is actually a continuum. While these thresholds are important, there are different thresholds that may be more predictive based on sensitivity or specificity. Now, when you look at the US guidelines, again, it's a class 2A to use dobutamine, what we just went over. Also, the DVI is obviously very helpful in these patients. And then 2A for the use of a calcium scoring, both for D2 and for D3. The threshold is slightly different. Just for women, it's greater than 1,300 in the US guidelines. But for men, the threshold is the same. Now, what we do know is when these patients undergo TAVR, these patients, the sicker the ventricle, the worse the outcome. So in general, they do better with TAVR compared with medical therapy. But when they undergo TAVR, your ejection fraction truly drives your outcomes. And then amongst these patients, patients with lower gradients have had worse outcomes compared with patients with higher gradients. Now, this was also assessed in the Partner 2 registry, and what's helpful is maybe understanding sort of how many of these patients you would expect to see. So only about 2/3 of patients in the Partner 2 registry had the D1 phenotype, and the others had, sort of one of the other phenotypes. And again, the patients with the low ejection fraction did worse, both in the first registry I discussed and in this one, suggesting that that is an important driver of outcomes. Now, I mentioned contractile reserve, and that certainly had a lot of importance for patients undergoing surgical aortic valve replacement. More recently, there have been some studies that have sort of questioned its utility for patients with undergoing TAVR. So this was a TOPAZ-TAVI registry of more than 300 patients. They all had D2 phenotype. They all underwent dobutamine stress. And as you can see, less than half of them actually had evidence of contractile reserve. Now, overall, about, you can expect that post-TAVR, you would gain about 8 points or 8% on the LV ejection fraction as assessed by echocardiography. The mortality is pretty high. So the 2-year mortality was 30%, but as you can see on the panel on the right, there was no difference between patients who had contractile reserve versus not. And similarly, in terms of gain in ejection fraction, there was no difference between those who had contractile reserve versus not. So it suggests that in the TAVR landscape, it may not be as helpful as it was felt to be earlier. Now, this has been extended for the TAVR on load trial, where really it's felt maybe moderate AS is bad as well. And so this trial will take patients with LV dysfunction, moderate AS, and then randomize them to TAVR versus medical therapy. And we should know the results of this pretty soon. Now, on the mitral side, again, the same question comes up many times. You have secondary MR or functional MR, which is a multifactorial issue most times, where you have LV dilation, you have altered geometry as a result, your pap muscles get displaced, your chordae get elongated and retracted, and then also the annulus gets stretched. So this results in functional MR. And it's unclear if, for the longest time, it was unclear if mitral edge therapies would be helpful in this phenotype. So we saw the results of MITRA-FR, which suggested that edge-to-edge repair was not beneficial in patients with this phenotype. And then you have COAPT, which had completely opposite results, which suggested an overwhelming benefit in selected patients with this. Now, this was a very interesting sub-analysis from COAPT, where they thought perhaps there's a difference in the severity of MR and the amount of LV dilation, and maybe that drives outcomes. So they had this MITRA-FR-like cohort within COAPT, which basically had patients with less severe MR and more dilated ventricles. And although there was a small subset, only 10%, this was a patient subset that did not appear to benefit with edge-to-edge repair. So Paul Grayburn and Milton Packer took this sort of and made this into a formal concept of disproportionate versus proportionate, and they proposed that patients who had more dilated ventricles and sort of compensated mitral regurg were more like MITRA-FR and less likely to benefit from that versus patients with COAPT who had more sort of disproportionate MR. Now, this was assessed in the Euro-SMR registry, where they kind of had a slightly different definition, but at the end of the day, there did not appear to be this sort of pronounced difference between proportionate and disproportionate MR. And then the other thing that I think is ignored in this equation is that the cutoffs for LV and diastolic volumes are actually different for men and women. And so for women, you may have dilated ventricle, indexed for sex, but it may actually show up as being proportionate when in fact it may be disproportionate. So women, in other words, are more likely to be classified as having disproportionate for the same level of LV dilation. So in conclusion, valve disease and LV dysfunction frequently coexist, and in general, these patients have worse outcomes compared with patients with either condition alone, but severe LV dysfunction, particularly low flow, are particularly poor prognostic factors. Additional testing, and we'll hear some of the talks on that, is helpful to distinguish this question of valve versus ventricle, and sometimes it may actually be both, and appropriately selected patients may benefit from valve interventions. Thank you again for the invitation. I look forward to the questions.
We have a question in front.
Is there any role of MRI to see ventricular scar in these patients?
Yeah, I think MRI certainly has an important role. You mean for mitral MR patients or for AS patients?
In fact, both are mitral more.
So I guess on the mitral side, I think there is definitely a role for MRI. I think, the discrimination of, ejection fractions, volumes, that ends up being much more, much better. I think for SCAR in particular, I think this construct is really based on the volumes rather than sort of the, myocardial contractility. And so, maybe Dr. Hamid may be better equipped to answer that. For aortic stenosis, Brian Lindman and his group have done a lot of work showing subclinical fibrosis as being important for aortic stenosis, and maybe that's sort of a precursor to having symptomatic aortic stenosis. And so that is still not sort of, ready for prime time, but that's a very promising aspect on MRI as well. I don't know if you want to.
Beside like mitral regurgitation, sometimes we have seen a patient like Dr. Srihari presented a few years ago, ejection fraction 20% mitral replaced and patient got better. But normally, generally, rule is that if ejection fraction is low in a mitral regurgitation, that is bad prognosis. So how did you decide that low ejection fraction mitral regurgitation and patient will do better?
Yeah, so I guess your question is, in patients with low ejection fraction and MR, how do you decide sort of what is the best way to move forward? And I think that's sort of, the heart team is incredibly valuable for this. You have interventional, cardiac surgery, imaging, many others, heart failure, at the table to sort of discuss these patients. And I think, this is one construct which is based on the ratio between the EROA and the LV index and diastolic volumes. And so if your LV is particularly dilated, then those patients, even with the perfect result, are unlikely to benefit just from a pure edge-to-edge repair aspect. But there are many other things that sort of go into the consideration, for sure. So RV function, for example, to what extent that's affected. Do they also have severe TR? Do they have pulmonary hypertension? There may be a lot of other factors that this is sort of just one aspect to that.
Last question is, in the old days we used to do valvuloplasty, to temporize or to see if the patient improves or to get them better. Has TAVR come to the point that we don't need to do that anymore? Do you think that it's all about risk-benefit ratio, and if these procedures are becoming low and low enough risk, is this all a moot point, at least for the aortic space?
Yeah, that's a great question, Hari, and actually something we struggle with. A lot of times, I think for patients with shock, so when you look at the TAVR risk score, it is clear that patients with shock and urgent emergent procedures have worse outcomes than sort of more elective outcomes. And I think, for patients with shock, usually, with aortic valvuloplasty, which is not particularly aggressive, assuming, you haven't caused AR, things like that, you can increase the forward flow enough that it's able to get them out of shock. But again, you're the expert in this, but, the level of shock certainly matters. So, it depends on where you are on that spectrum. So if you've just had a cardiac arrest, then I think, your likelihood of survival, no matter what you do, is going to be low. But I think, if you have lesser degrees of shock, there may be a role, and there have been published case series on this, on using TAVR. There was a European publication on looking at this. The outcomes are promising. I think, as with all sort of published data, you've got to look at the patients that were included in that, and so there's clearly some selection bias happening. So at the end of the day, I think it still ends up being a fairly individual and sort of team-based discussion. There may be some patients where, the appetite is for, slightly higher risk for more reward, and I think you might consider TAVR in those, especially maybe it's a younger patient. But it's sort of an older patient, more comorbidities, then, BAV is a nice way to temporize that.
Thank you. A great presentation. But back to the question of myocardial fibrosis and the ventricles, I think there's a few articles out there by Philip John Naru and Jerome Bax on the staging of aortic stenosis based on the extent of the heart damage. So they take into account not only the left ventricle, includes the pulmonary pressures that, all the way to the right heart. So, obviously if the heart is, damaged all the way to involving the right heart, the prognosis is bad. And I think that staging as well is very helpful. It has extended that staging. I believe there's another group in the US who looked at mitral regurgitation cohort as well into the staging classification. So I think looking not just the ventricle, but essentially everything, the whole heart, including the right, ventricle as well, and how the patient is, to decide whether a patient, what kind of intervention should happen. And back to the myocardial fibrosis and MRI, and all these advanced techniques, I think, play such a key important role, especially in our current research, is trying to find that sweet spot, right, when to intervene. So that before the heart gets too extended, and that's when we see all those sick patients in ICU, and what do we do? So I think huge role for advanced imaging with all this innovation, so really so that we can incorporate those tools into the guidelines.
And this is a great example of how we tend to think sometimes simplistically. We talk about the ventricle or the valve. But the truth is it's also the lungs, it's the elevated PVR, it's the artery failure. And so this brings back to the concept of interventional heart failure, which is that if this area, the valve and the ventricle, is maybe only 40% of the low output state, you can only impact 40% of the low impact state, maybe only 10% of that, right? And so then the patient, so this is what portends why some patients do worse and some patients do better. It's really about the totality of what's making them sick. And so I think we do need to evolve past that. The heart failure people are good at this, and that's why we need to work with them together. So.
Yeah, that's what I'm saying, because a lot of times we refer the patient, they get a H-fair repair, not everybody gets better. So we need a better evaluation so that we can benefit those patients better, We can select,
Okay, great. Thank you. We do have one talk is not here today, so we have plenty of time for discussion, so we're not really behind. So next is Dr. Eckman, Peter Eckman, high-yield peri-operative maneuvers for mitral therapy with low EF.
Thank you. And so kind of to pick up on this theme that you alluded to, is very often in patients with low ejection fraction and mitral valve disease, we worry about these patients, and they often don't do well, but there certainly are settings where it does make sense to intervene on them. I have a number of disclosures, the vast majority of which is donated to our foundation, but just to acknowledge those. So I think when looking at patients with severe heart failure, low ejection fraction, mitral valve disease, upstream, I think, is the most important part of the perioperative process. And upstream, multidisciplinary heart team evaluation is so critical between imaging, interventional cardiology, heart failure, cardiac surgery. The context is always, why are we doing this? Is this a patient that's symptomatic? Is this a patient that has high risk of mortality? What is our target? I think the next question that we have to address is, what is the procedure being considered? Is it TEER? Is it mitral valve, transcatheter mitral valve replacement? Is it mitral valve surgery? Is it a ventricular assist device or something totally different? There's often I guess I like to think of it as a social pressure to these patients. They're often sent to our practice or one of our partners with the explicit request of, hey, I think this is a good patient for a clip, and we might have a different opinion about that, and no one likes to have their wedding canceled the day of the procedure, and we have patients that come from a ways away, and they're pretty mad when we say, well, no, you're actually here for a consult, and we're just going to talk about what we're going to do. You're not going to actually have your procedure today. And then I think another question that comes up in these patients is whether we should do this procedure. Is it too late? And I think these are challenging questions that we all face. The next question, which I'm going to spend a bit more time on, is when should we do this procedure? And very often, upstream optimization makes a big difference. And then briefly, where to do it. These are typically not ambulatory surgical center type procedures. Often you need to book the hybrid room and so on. I also spend a lot of my time as a heart failure cardiologist and an expert in ventricular assist device. Can't help but plug the context of when we talk about these patients, and obviously many of these are very older patients that are not suitable for things like ventricular assist device, but when we're talking about patients with a 30% one-year mortality, contemporary VAD outcomes are better than that, and this is from the HeartMate 3 trial. It was published a few years ago now, and more recent data would suggest that the centrifugal flow, which is code for HeartMate 3, a 2-year free from stroke and still alive is on the order of 80 to 85%. And so keep in mind that people getting LVADs are not necessarily those that are on multiple pressors and ECMO in the ICU. These are people that can have a pretty good prognosis, and so in some cases, leaving the valve alone and going right to definitive treatment for the ventricle makes a lot of sense. When to do the procedure, I think, again, is really essential from a heart failure cardiologist perspective. We're big on medical therapy, and there are now, pillars of 4 classes of medications that are really essential. And I often see patients that have been on what I would consider sort of homeopathic doses of some of these medications for some time. And I think one of the lessons that was reinforced in the co-op trial is that a substantial fraction of patients, their MR gets better if you treat the ventricle more vigorously with medical therapy. Resynchronization may have a role, and sometimes is either underutilized or could be optimized. I'm also a huge fan of PA catheters. I think that's an area where the interventional cardiologists and the heart failure cardiologists certainly have some agreement in the role of procedures. It's really helpful to know what a patient's cardiac output is, and that helps us with our risk triage. And I am very reluctant to weigh in on these sorts of challenging patients without understanding their hemodynamics and knowing how sick they are. It's also essential for us to know that their congestion status is optimized. I think it's also valuable in these patients with low EF and mitral regurgitation to have at least thought through with the heart team, and to some degree to have had these discussions with patients, what are the bailout options, or are there bailout options? In some cases, it's helpful to go in knowing that this is someone we are not going to put on ECMO, or this is someone that we would try ECMO for a few days, but they are not a candidate for durable mechanical support. That upstream decision making helps empower the patient and helps give clarity to the team, so it feels like less of a scramble if things don't go well. A couple of points in terms of medical optimization. There's been some recent data. This was a prospective study of 118 patients that showed the angiotensin receptor neprilysin inhibitor Entresto was superior to ARB in terms of reducing effective regurgitant orifice area in mitral regurgitation. So just because someone's been on 5 milligrams of lisinopril for years doesn't mean that they're optimally managed, and there may be opportunity for medical improvement. Biventricular pacing has been known for years to decrease mitral regurgitation, both in the acute setting and on a sustained basis. And a number of patients most have a decrease in mitral regurgitation, and so this is something that could be considered as well. My take on right heart catheterization is doing high-risk procedures without this is like flying an airplane blindfolded. Why do it? Why not get the right heart cath that gives you so much information? This is a little bit unrelated, but it's a national readmissions database of 236,000 hospitalizations in cardiogenic shock patients. Only about 10% had right heart cath on admission. That group was more likely to have heart failure, less likely to have ACS, and a little bit less likely to have cardiac arrest. But what I want to highlight is that the patients that had right heart catheterization had lower risk of death, and this excluded the cardiac arrest patients. And so this is a very low risk intervention that provides a lot of information so that we're not flying the plane blind. Another thing that comes up is patients that are in shock that have severe mitral regurgitation, and what can we do for them? This is from a series from our group looking at 11 patients that were in cardiogenic shock, felt to have inoperable MR, had salvage transcatheter clipping. Most were able to come off meds, and 72% were alive at 30 days. Again, these tend to be people that are not eligible for more aggressive treatments. There have been a number of publications since highlighting this, that it's, from The Simpsons here, certifiably not insane to do this, and to do salvage mitral clipping for shock patients can be helpful. These are obviously people where you're looking to get them out of the ICU, get them off a balloon pump, maybe stabilize them so their renal function improves, and they might be a surgical candidate. Balloon pump support is another trick that is available in this setting. There's a report of using this to facilitate temporally remodeling and maybe a little bit of LV shrinkage to facilitate coaptation or clip placement. There was another study doing propensity matching of people that had a balloon pump versus not. They were sicker and they had a little longer length of stay and more adverse events, but it wasn't clear that it had a substantial benefit. Another center found that it did shorten postoperative ICU time of patients that were managed with a balloon pump peri-procedurally. There's been some work and some publications on the use of Impella in this population, largely small series, in some cases using the higher potency Impella devices as a bridge to surgery, or as a bailout in someone who has a procedure and continues to have persistent shock or RV failure. But unfortunately, it has also been described to cause valve injury, and there have been at least a couple of case reports of using this to support clipping. Intraoperatively, a couple of things that we often find useful, and a lot of this really has to do with treating RV failure, which can crop up in this patient population. Inhaled pulmonary vasodilators, inhaled milrinone, and some suggestion milrinone may be superior to dobutamine and nitroglycerin. We'll sometimes use nitric oxide in these patients as well. The other part of the peri-procedural management of patients with MR and low ejection fraction is post-procedurally to remain vigilant for RV failure. And we find serial hemodynamics helpful. Echocardiograms can be helpful, though often they don't have good imaging windows. We often follow lactates. It has its pitfalls, but if someone's lactate remains elevated, we're a lot more worried than if it normalizes. And don't be afraid to leave a PA catheter in place for a day or two while you're managing these patients. Long term, I think the majority of these patients, if they're not already established with heart failure specialists or heart failure programs, they are going to have continued needs. When you look at the COAP trial, I think it was 25%, I think at 1 year, maybe it was 2, I may not have that right, are dead within a year. And so these are sick patients, and they're dying of heart failure eventually. And so these are patients that even if you are able to improve their symptoms and their quality of life with, for example, transcatheter mitral valve treatments, they will have ongoing needs. And so the heart failure team is generally an important part of their ongoing management. So I'll stop there. These are challenging patients. I'd be eager to hear if others have insights, suggestions, or questions about how to assess and manage these patients. But again, I want to thank the moderators and the program directors for inviting me to present and discuss this challenging topic today.
Peter, thank you. That was a great talk. Really enjoyed it. So I have two questions. First is, from a big picture perspective, since publication of COAP, we've seen sort of this explosion in patients in hospitals that are doing edge-to-edge repair. And, majority of the clipping is happening for functional MR. So what do you think is the role of the heart failure community in sort of having a role in, I don't want to say enforcing, but having sort of some say in how, as you said, a lot of these patients are on lisinopril 2.5 check, beta blocker, carvedilol 3.125 check, and then they go for their clip. So how do you make sure that in this era with the current, latest heart failure guidelines, that what role do you think the heart failure community has to play in that?
Well, I think we should be involved in these patients. I think, it could be argued one of the reasons COAPT was a successful trial is that they had very strict upstream heart failure management. I'll be honest, I thought COAPT was going to be a negative trial. I mean, I was never very enthusiastic about clipping. I kind of looked at it as, oh, good, the MR went from 6+ to 4+, big deal. But I was wrong, and I think have really learned that there is a symptomatic benefit from it. There's, this really works. But I have also seen a lot of patients that have severe MR that it gets a whole lot better when you optimize their heart failure. We've worked on this in our own practice. Often the logistics are tough of the day Paul's in clinic, I'm out of town, and obviously we're in a big practice. We've got a lot of people doing both roles, and so it certainly isn't dependent on a couple of us. But getting those logistics in place is a challenge. I think sometimes there's some subtle pressure of a patient is referred for a clip, and I'm the bad guy canceling the wedding, and so we really do try to have the heart failure team involved in the majority of these patients, and when we look back, we do see the majority of them. But I think it makes sense for us to be part of the heart team in making these decisions so that people aren't getting clips that then have a lot of problems, and then we have to deal with sort of the downstream mess, because when they keep coming back with heart failure, they're not coming to Paul's clinic, they're coming to my clinic. So we want to be part of their care.
So as a follow-up question, I guess the converse is, so let's say you see a patient, and we face this all the time, they come to Mitral clinic, they've been referred for a clip, and you say, no, you have functional MR, you need to go see my heart failure partner. And I've spoken with a number of teams, and to understand sort of how they do this, what is the time frame? Do you give yourself, I'm going to give you 3 months, and I'm going to try to optimize, or how do you optimize that? How do you work?
It depends how far off they are, and that can be surrogates like, looking back at their history, why are they on minimal doses? I mean, if their blood pressure is 80 and they say they've tried, I'm not going to push it as hard. On the other hand, if their blood pressure is 130 and their creatinine is 0.8, and they said, well, my family doctor is nervous because my blood pressure was less than 100, those are people I'm going to push harder. Usually within a month or two, you get a sense of, are they tolerating the escalation or not? That may be a point at which you redo the echo and see if you've made any headway. I think usually you have a very good sense in 2 to 3 months. And if they feel a lot better, then often they say, you know what, I like these new pills. That Entresto you gave me is making a big difference. I'm okay to wait on this clip.
So if I may, I think that this is a big issue that we've been dealing with for many years. It's not something new. In other words, interventionalists get referred patients for all kinds of procedures, and all of them need some type of medical therapy and waiting and optimizing. This is where the heart team comes in, which is that if you send a patient, you're sending not to a procedure, you're sending to a heart team to evaluate for the procedure. And during the evaluation process, you should optimize medications. And that's how we teach the referrings, that it's a positive thing. You're getting this whole thing. You're getting this second look with multiple people involved, so when multiple people are involved, they won't be insulted. Because now you have a group think of, and everybody knows if a bunch of people together is always going to have a better and more comprehensive approach, and more, a lot of the referrings can't do labs twice a week in the outpatient setting. They can't do micromanaging all those medications and making sure the patient is staying out of the hospital. So if we pitched it in the way that we're doing this, and then some of them will get the clip, some of them will get TAVR, some of them, or maybe you can defer it for another 6 months or whatnot. I think that's where our field has to go. And I think this is part of that discussion to communicate back that the field should be patient-centered.
One thing that I have found really helps too is to make sure that the patient understands that you are doing internal communication. This is not a matter of, well, Dr. Srihari said I should get this valve, and you're telling me I should take more pills. Do you guys even talk to each other? And making sure that the patient understands that we are communicating. Yeah, we text. But that we are communicating, and that otherwise they feel like they don't have a cohesive narrative to their care. And I think that makes almost a bigger difference than communicating with the referring docs. But Dr. Hamid, what's your experience been in this?
Yeah, no, that's great, because we have close relationship with our heart failure colleagues in Colombia. We started the heart failure meeting every week where we discuss key patients, not many, less than 10. The imaging people, we are there to review the images. These are mitral regurgitation, tricuspid regurgitation on the service or in the outpatient clinic. And we discuss them, include them all the right heart numbers, their medication, and discuss the interventional plan. And I think that is key, that communication, as you mentioned, and ultimately from that meeting then translated to the patient.
Yeah, comment from the front.
How is this new phosphodiester inhibitor? Where does he go
The question is about vericiguat. I have to confess, I haven't had personal experience with it. I'm familiar with it. And I think that's another option for patients with heart failure, and it's been presented mostly as a people that have borderline blood pressure and so forth. Quite frankly, part of what I've run into is that it falls into the same financial category as Entresto and the SGLT2 inhibitors. And if I'm having to prioritize my patients' drug budgets, I'm pushing those other two. And so I really haven't had a lot of patients that have still had the budget for it. And I'm not aware of any data on the impact on MR, although I would hope that it makes it better. So I don't have any experience. I don't know if any of the panelists do or if anyone else in the audience does.
I had one patient, blood pressure low, so we gave it, I don't know, symptomatically patient got better.
It helped. Yeah, that's good to hear. It's nice to have more
Patient who was low
options.
blood pressure.
Yeah.
Okay, wonderful.
All right, thank
So
you.
let's move on. We'll have Dr. Hamid speak on interventional myocardial solutions.
All right, thank you so much, CBI, for the invitation. And today I'll be talking to you about interventional myocardial solutions. I have no disclosures. As you heard from the other speakers, and there are multiple heart failure devices in the current literature. Interatrial shunts, reflex activation therapy. You heard from the other speakers of valve repair and replacement. There's also pressure sensors, cardiac contractility modulation, or phrenic nerve stimulation. And I've been really privileged and really involved in the one therapy, which is the left ventricular reconstruction, which is the Ancora, and I'm going to talk to you more about it. So as Dr. Naidu mentioned in the first talk that, in heart failure with reduced ejection fraction therapy, there's this therapeutic gap. He mentioned that, of course, all these patients are medically optimized, as you can see on the left-hand side, and these patients obviously are treated medically, and we would like to avoid them going into LVAD or transplant. And there's this therapeutic gap, as he mentioned, where interventional heart failure can help these patients. And so over here, this is the restoration system, the left ventricular, restoration system, which is the AccuCinch, to fill in this therapeutic gap. Sorry about that. And so one goal of the heart failure therapies is these patients, you have remodeling of the left ventricle and other cardiac chambers in the heart. And you want these patients to eventually go back to their normal heart state. And that's what we call reverse remodeling, whether or not is it with medical therapy or with advanced interventional medical therapy. And so all these therapies in the current literature, including medical therapies, have been associated with reverse remodeling, and these are associated with improved outcomes. I do have to thank Dr. Burkhoff for this, and he taught me about this in terms of reverse remodeling and the components of this. It involves in biological and physiological remodeling. So biological remodeling includes all the components, including the blockade, neurohormonal blockade, all these activation, and these include the drugs that we give as cardiologists give these patients. What happens to physical remodeling? That's when Dr. Naidu mentioned the interventional heart failure therapies that is currently, in the market right now, and one of which is the AccuCinch device, which is the left ventricular restoration system. And so there's a small niche group of patients that can benefit from this therapy. And we found the patient population over the last couple of years with our early feasibility studies that these patients are symptomatic despite guideline medical directed therapy. What are they? The left ventricular ejection fraction between 20-40%, NYHA between 2 to 4, the dimensions on echo more or equal to 55 millimeters with not significant mitral regurgitation. So a little bit more about the AccuCinch system implant. It basically is a cinching device right below the mitral annulus and really essentially trying to reduce the size of the left ventricle while promoting the cable and slider incorporation, as you can see on the picture on the right-hand side, into the tissue for long-term implant durability. And I'll show you more pictures with regards to the pathological specimens. So of course, with any interventional heart therapies or any valvular heart therapies, WEIGH images are very important. Echocardiography, we screen these patients. I do in the screening lab, in the core lab. We look for the LVEF, 20 to 40%. It can be challenging with images such as this, and we advise psychs to provide us with contrast so that we can really delineate the endocardium borders of the left ventricle. We want to avoid these patients with significant mitral regurgitation and also calculate the left ventricular end diastolic diameter.
Cardiac CT is important in screening for these patients, looking specifically at the LV anatomy, in particular the wall thickness. As you can see on the top left-hand side, the wall thickness is measured about 10 millimeters, 15 millimeters, and 20 millimeters below the mitral annulus. And you can see on the left-hand side here, it's really thick, and there's no exclusion. In comparison to this image here, you can see the wall of the left ventricle is very thin. So this patient is not really ideal for the AccuCinch because you don't want to cause a left ventricular perforation. Besides the wall, cardiac CT, we look at the vascular access and the anatomy, looking at the diameter, tortuosity, and calcium as well to see whether it's suitable with the 20 French sheath. And so here's a video of the AccuCinch system device, the procedure itself, the access of it, the delivery with the advancement of the track cap and advancement of the AccuCinch implant. You can see with completion of the AccuCinch implant procedure by cinching and acutely reducing the size of the left ventricle. And I'll show you a couple of fluoro images as well. So here you can see on the left-hand side, the guide catheter position relative to the mitral valve. We do TE guided as well, but it's not as intense as a mitral clip. So the TE is really is used in the first part of the procedure for the guide catheter position, tangent to the left ventricular wall. The next step, advancing and navigating the nav cath and wiring of the left ventricle across the left ventricle. And you can see on the right-hand side the final position of the guide wire parked in the descending aorta. The next step, really advancing the track cap advancement on the left-hand side to the junction of the free wall and the septum. And on the right-hand side, that's the final track cap position. You can see parallel about 10 to 15 millimeters below the mitral plane. Finally, delivering of the AccuCinch implant, you can see on the left-hand side, the anchor and the slider delivery sequence is repeated. You can see all around the left ventricle. It's a repeat procedure. The echocardiographer can actually walk out of the room over at this point until the desired implant length is actually reached. The final step, which is the cinch sequence, you can see in this diagram on the left-hand side, pre-cinch, you have a cinch and lock catheter as displayed in the diagram here, and the in-process cinch. And finally, the completion of the procedure itself is all seen on fluoroscopy, and you can see that there's a 9.5 millimeter slack on the left-hand side, really reintroducing for the flexibility, and finally post-cinch after the cable is cut. Measuring the left ventricular dimensions, the cinching process is done by fluoroscopy. You can see these are 3 examples. On fluoroscopy, the reduction of the left ventricle up to about 12 millimeters. Here is a diagram we can see from animal studies in terms of the pathology where the implant is really integrated into the left ventricle wall up to about 90 days. There are some patients in the cohort, you can see that there's cable discontinuation, and I will show you the results of our 12-month outcomes despite the discontinuation of these cables. And so I'm really privileged that I'm involved in this and analyze this data where we look at all the early feasibility studies. This was 3 US and 1 European study a couple of years ago, and we look at the 12-month outcomes. Out of these patients, we selected 41 patients who met the criteria for the current pivotal trial, which is currently ongoing enrollment of left ventricular ejection fraction, similar like I mentioned before, 20 to 40% with no significant MR, and looking at the safety and efficacy of these patients. The baseline characteristics of these patients, of these 41 patients, average age about 55 years old. They do have the standard cardiac history of hypertension, hyperlipidemia, type 2 diabetes. Note that they do have, a previous cardiac ICDs, and all of them are, NYHA class 2 to 4. In terms of echocardiography baseline characteristics, you can see the left ventricular ejection fraction of 29%, no significant mitral regurgitation, and you can see that there's significant enlargement of the systolic diastolic volumes and also their diameters. In terms of the results, there's significant reduction at 12 months in terms of the systolic and diastolic volume, and including the end diastolic diameter. There's no significant difference in terms of the right ventricular function or the left ventricular global longitudinal strain. We think that is due to the numbers, and also in terms of the right ventricular function. So this is just a schematic diagram that trying to show to you the improvement of left ventricular and diastolic volume. And as I mentioned to you in the first couple of slides, that remodeling concept of biological and physical remodeling, we hypothesized that the AccuCinch induced what we call a physical remodeling in the first couple of months. And this is then translated to a biological reverse remodeling that extends all the way up to 12 months. And you can see, due to this reverse remodeling, there's significant improvement in the left ventricular and diastolic volume all the way up to 12 months. This improvement in the left ventricular and diastolic volume is translated in improvement in the quality of life of these 41 patients from KCCQ to 6-minute walk test, and these patients do really well. As I mentioned to you from the pathology slides, that we do notice there's cable discontinuity in about 40% of these patients. Now, despite the cable discontinuity, you can see that this reverse remodeling is still translated all the way to 12 months, and we believe is due to the initial physical effects of the reverse remodeling. And so an example here, acute procedural results, the reduction in the left ventricular reduction. Procedure time is about, of these 41 patients, about 122 minutes. An average about 14 anchors were placed with a left ventricular reduction of 9 millimeters. An example over here on the left-hand side of a patient, you can see 8.7 millimeter LV reduction. On the right-hand side is a cardiac CT that was done at baseline and also at 12 months, which is highlighted in blue, and you can see post-AccuCinch there's significant reduction in the CT remodeling at 12 months post-procedure. So in summary, AccuCinch, preliminary data of these 41 patients have shown significant reduction in LV volumes through 12 months. The concept of reverse remodeling after the initial physical effects, and these structural improvements really have shown improvement in the quality of life of this patient. The key is really the role of imaging in selection of these cases, and really right now very proud that we are undergoing the pivotal study, enrolling patients to assess the clinical and safety and efficacy of this device in this group of patients. Thank you very much.
Thanks for your presentation. We've been fortunate to be involved in that study as well, and I think really certainly a promising technology for these patients. I know some of the early feasibility studies focused more on the MR population, and now they've pivoted to look more at the LV remodeling component. Any comments on that from your perspective?
Thank you very much. Yes, I reviewed a couple of patients of those with significant mitral regurgitation. I think it's really down to the etiology of the mitral regurgitation. Is it a left ventricular annular dilatation? And so I think it really down to, I think, the etiology of the mitral regurgitation. Otherwise, the outcomes of these patients, you'll see not being effective. We also evaluated the AccuCinch also in patients with previous mitral therapies. There have been cases I know where these therapy, the AccuCinch, have been done in patients with really enlarged left ventricle, trying to cinch the left ventricle before the mitral clip procedure. So there's a possibility, but I think we do need more data before we venture out into this space.
It looks like the criteria have a lot to do with EF. Do you think that EF is more important than volumes in terms of predicting, and is there a threshold effect on the volume reduction that you need to see? That sounds like it depends on whether you think that the volume is what's begetting more remodeling.
I think it's based on the data. I think it's more of the volume that you can see the reduction. Now, some other left ventricular restoration devices, you see that's a correlation with LVEF as well. I think this is just a small cohort. We didn't see that much reduction in the left ventricular ejection fraction as much as the volume. But I think that pivotal trial, I think, would be great to evaluate that.
Well, I think it was interesting, too, that you had 30 milliliter decreases in the volumes, but your stroke volume changed by, I think, 5 milliliters or something, which would suggest that the EF is likely to stay the same and the output's the same. And
that's right.
So I think the concept that you start with mechanical remodeling that may induce further biologic remodeling it will be interesting to see if it's, is that really the mechanism of efficacy, but the fact that it leads to the as much remodeling as it does is really encouraging.
Yeah, absolutely.
Thank you. That was actually really a very nice presentation. And I actually really like your construct of biologic versus physical remodeling. So, one thing that is interesting is, when you compare this therapy to, for example, medications, there you actually have biological remodeling first, and then you get the physical remodeling. This is sort of doing the opposite. You're actually forcing physical remodeling initially, and then, you're trying to engender biologic remodeling after that. And there have been a number of surgical procedures that are attempting to do the same thing over years. And, I guess, there have been dedicated remodeling devices, but then we also had the Stitch trial. It had, surgical remodeling as part of that. And unfortunately, that approach, at least in some of those surgical trials, seemed to not be as beneficial. What do you think, looking forward? What do you think about that?
Great question. My thought process was these patients in the trial, they already have been optimal medical therapy. So they've been given the chance for the biological reverse remodeling. And then you give them the opportunity for that physical remodeling with the interventional heart failure devices, be it AccuCinch. And whether or not that combination kind of induces a little bit more that physical effects and then into the second phase of the biological physical remodeling. That is something which is my thought process when I was discussing with Dr. Burkhoff, whether that physical effects accentuate that biological reverse remodeling on top of that medical therapy, perhaps. And I think, the next question is finding that sweet spot of, the criteria and selection of these patients, which was very hard during our early feasibility studies that we were struggling during that 4 studies. What is the best suitable patients for this therapy for the pivotal trial?
And I think one of those EFS MR patients was, I know one we had that was 8.5 plus centimeters and had sort of no other options, wasn't even clippable, and we used it almost as a bridge to a clip.
Yeah,
so I guess we shouldn't be shocked that it wasn't super effective, but also it's, it's an early trial. That's where you got to look for that niche. Where is it going to be effective?
That's right, and really getting them early on. So then the question is when, right? When you optimize this medical therapy, do you sit on them? Do you refer them early on for this, interventional heart failure therapy? That's the next question and the revolution, I think, in interventional heart failure. What are your thoughts, Dr. Naidu?
No, I agree. I think this is, I like the question because when I was a fellow, Mike Acker was doing the trial for constraining the heart. And so the question, it's amazing that 20 years later we're still doing the same thing, but finding ways that can do it with, maybe it's because it hurts the heart too much when you do that, and if you can do it minimally invasively as an adjunct. So thank you very much.
No problem. Thank you.
So I don't have personal experience with Myocore and have to admit I don't know much about that specific technology. I was a little skeptical up front, in part because, as Dr. Kumbhani alluded to, we've been working on this for 20 years and prior efforts weren't very effective. I was involved in the parachute trial, for example, and we've sort of tried this many times, and at some point we're going to, if it doesn't pan out, we're going to have to admit that we're on the wrong track. But I was really encouraged by this EFS data that showed favorable remodeling, and the 6-minute walk increases, the KCCQ improvements were on par with what we see with CRT. And so I think I do have some optimism. Maybe it's just my inherent bias of that I think we're getting better and we're learning, and I think our imaging is better than it was 20 years ago in terms of understanding the patient population. I know, the screening process for these patients is really diligent. They're getting all sorts of scans. They're going through thorough medical review. I think it's getting harder to find that niche of patients, but I think we're doing a much more thoughtful job of selecting the patients. So I'm still optimistic that there's going to be a space for effective interventional remodeling type trials for these patients.
And do you see that sweet spot that Nadira showed? Is that a pretty good, large segment between the drugs and the MCF?
I think so. I think for the purpose of the trial, what I have run into is I've had some patients that they're not doing great on medical therapy. They've kind of peaked out on what they can tolerate. They're sort of functional class 2, maybe 2.5. I mean, NYHA, as you and I have talked about before, NYHA functional class is such a terrible definition that I think there are people for whom, I try not to, but frighten them with the idea of LVADs. Almost nobody is excited to hear about that. And they say, well, maybe this will stave off the need for that for a few years. And I think a lot of people are very open to that concept of, oh, sure, I'll do something that's percutaneous and maybe a day or two in the hospital if it's going to help me live longer. And there's a lot of people that, I'm an LVAD enthusiast, but there's a lot of people for whom it's just not a good therapy. And so I think there definitely is a big space there for patients that have the LV structure that is suitable to be made better. When we've peaked out on what we can do with the biologic and the pharmacologic remodeling, and that there may be mechanical options to make this better.
Another, I guess, quick question. Since you have experience with this, these are sick ventricles, and, do you see this being a nidus for arrhythmias in the future?
I hadn't thought about that. I think we have to assume that it could be. Our experience has been relatively limited just in terms of the number of patients we've had, and what's hard to tease out is if you've got someone with an 8-centimeter ventricle and they have VT, could have just been their ventricle. So until we've had someone where it's just refractory and we map it and the EP's like, oh, it's this terrible device, what did you do to them? I think we need to remain cognizant of the potential for that, but at least in our individual center's experience, we haven't seen it.
Okay, in the interest of time, we'll move on to Dr. Khalique, who talked to Omar Khalique, talked to us about when and how to evaluate the myocardium before therapy. So going on this theme.
Thank you. Well, we have a timer today.
Just for you.
Thanks, Paul. So when to evaluate the LV myocardium? Always before therapies and periodically. How to evaluate? So I think that becomes more of a philosophical question sometimes, and I don't think we exactly know, but we'll try. So we know that various LV parameters predict poor outcomes. That includes LV size, LVEF, strain, contractile reserve, gross fibrosis by late gadolinium, and interstitial fibrosis by looking at the ECV parameter from MRI. But something to keep in mind for all of these types of scenarios is whether improving these parameters actually improves prognosis. So as has been discussed in detail, we have these many types of devices in development now. There's ventricular restoration, there's these sleeve type devices which have been used, there are valvular devices for that space, shunts for the HFpEF space, etc. We know for the valvular disease space, for MR, this has been well studied in COAPT, and that when we have the right ventricular size and enough MR and a good enough EF, we have good outcomes. And then in other quadrants, we have poor outcomes where the MR may not really be reflective of valvular disease, but more of the ventricular state. So I'm going to keep it pretty simple. So for ischemic heart disease, we have several old studies saying that more CMR viability by late gadolinium, so that's gross fibrosis, means more LV recovery after revascularization. So I think that's pretty straightforward. For non-ischemic, we have many imaging trials. This is one where they looked at the re-worsening of LVEF after the initial improvement of new onset non-ischemic cardiomyopathy. And what they found was that the extent of late gadolinium, but not only the presence, was what really was associated with the worsening of LVEF after the initial improvement. So this was another study, and we'll talk more about contractile reserve, but this study actually showed that only LV contractile reserve, this was done on dobutamine stress CMR, but can also be done on echo, predicted LV reverse remodeling over time. And these various other parameters did not predict remodeling, and that includes LV strain, gross fibrosis, and interstitial fibrosis. So talking a bit more about contractile reserve, I think one weakness which everyone should be aware of is most of the imaging studies out there define contractile reserve as an increase in stroke volume by 20%, and that's somewhat arbitrary. And we all know it's really more of a continuous variable, right? It's not that you just get 20 or you don't. You can get incremental improvements, so it's a bit more complex. But looking at all the data, we know that LV contractile reserve overall usually predicts mortality, but sometimes predicts LV recovery. So if you look at the study in the bottom right, it's an AS study, low flow, low gradient AS. The absence of LV contractile reserve predicted mortality, but it did not necessarily predict a lack of LV improvement for survivors. So I want to end by talking a little bit about fibrosis. So interstitial fibrosis, I think I hoped and others hoped would really be the answer for a lot of what we look at and whether things are going to improve. But it turns out not to be the case. So this is a very interesting trial, Peri-operative trial. And I forgot the name of the medication, but it was basically a medication that's been used for regression of fibrosis in IPF, lung disease. But this was a cardiac trial. So what it showed was that fibrosis by ECV actually decreased in the treatment group. So fibrosis got better, but increased in the control group. But the other thing it found is that there was really no impact of the ECV change on the change in LVEF or functional status. So this, along with a few other studies, really shows us that LV function is truly multifactorial, not only based on fibrosis, and it's probably more complicated than we're making it out to be, like everything else. So how to evaluate the LV myocardium? We're still thinking. So LV size, we saw, this is actually a typo from COAPT, LV ESD, 70 millimeters, LV function, maybe 20%. LV strain, nothing compelling. Gross fibrosis, yes. ECV, not as compelling based on recent studies. But I think we need better prediction models for LVEF recovery, which are tied to prognosis. And the other thing we're looking at here, which is very different from everything that I showed, is that we're affecting the heart in different mechanical ways with all of these different devices. And that may have unforeseen effects, good or bad, and maybe we can fundamentally change some property which makes all these trials obsolete. I don't know. Thank you.
Any questions from the audience? It's interesting to me that, seeing this for a while, I'm struck with the analogy, and not to go backwards, but that, we trained a lot in, when to extubate patients, and we do all these things, and at the end of the day, we're like, oh, you know what, let's just give it a try, right? So I'm just looking at the whole thing, and, the field has moved towards MRI and looking at all these, and we're doing all of those things, but at some point, you just have to make a decision about these therapies. And so I think as long as we're very thoughtful and using our best abilities and then making a decision, and that's why the merger of heart failure intervention is very good, because, the interventionists, for lack of a better word, are a little bit more cowboys. They want to just try it. And then the heart failure people want to be a little more methodical, and I think that makes us good, especially in this situation. But what do you think about that? Do you think we're just getting into more and more details, and we just don't, it's very hard to see the forest for the trees?
Yeah, so I gave a similar talk on the RV yesterday, and I just don't think we understand this stuff that well. I mean, we're kind of, I think maybe even more in this space, that we're kind of floundering a bit on where exactly are those sweet points and how do we really detect that. I mean, the very simplistic measures seem just as good as the very complicated ones that we're trying to use. So.
Well, I think that's something in terms of, I'm glad you brought up the RV, because I think so much of the time we spend looking at left-sided valve disease, we focus all of our attention on the left side of the heart, and the right side makes a big difference there too, and the RV is so much harder to evaluate. And I've often joked that because assessing who's going to need an RVAD after an LVAD is such a big area in the LVAD community, there's 20 papers on this, which always tells you that we haven't figured it out yet because people can keep writing papers about it. So I feel like the challenges we have in assessing RV function and integrating that into how the LV impacts us is probably this whole other thing. You know, we spend a lot of time looking at the amount of fibrosis and so forth on the left side, and we're kind of ignoring this giant other ventricle that may be a bigger contributor, but is so hard to evaluate. If I can pontificate for a minute on, I think, the importance of the forgotten ventricle.
Yeah, exactly. Well, I think part of it is what we think we understand better. We think we understand the LV better, but I'm not certain that's true. RV, we know we don't understand it that well. And we kind of
confident in our ignorance. Yeah. I think we should probably move on here. Thank you very much. We appreciate your presentation, Dr. Khalique. Finally, we'd like to invite Dr. Shah up to speak about atrial shunt solutions from an interventionalist perspective. This is another area of overlap between interventional and heart failure, and so eager to hear from Dr. Shah. Thank you for joining us.
Thank you very much. It's a pleasure to be here. I guess there was supposed to be a heart failure specialist discussion, yes. So I was hoping they would cover a lot of the heavy lifting here, but now I have to sort of take over some of that perspective. So I'll start off with my disclosures, and I think one important disclosure is that I've never actually done one of these procedures, and I also did not sleep in a Holiday Inn Express, but I will do my best to bring you up to date with where we are. So I want to first start off with my perspective of what makes an ideal interventional procedure. And I think that there are two sets of criteria. One, of course, the most important should be the patient, and then second is the actual interventionalist. So to me, I think the ideal interventional procedure is one where the patient immediately feels better. There are excellent reproducible long-term outcomes. Of course, a procedure should be cost-effective and, of course, safe. And from an interventionalist perspective, it's nice if they're quick. There's immediate procedural gratification. What I mean by that is that you see a finding either on echo or angiography or whatever that just looks good and makes you feel like you actually did something good. The results are uniformly reproducible, ideally low stress and fun. So, you know, we're all going to have a different perspective of what procedures actually fit these criteria. I mean, for me, I think TAVR, PCI for STEMIs, balloon mitral valvuloplasty for mitral stenosis, mitral valve and valve, those are some of the more fun procedures that I like to do, and I feel fit most of these criteria. There's others that we do I think don't necessarily meet all of these criteria, but are still certainly reasonable to do. Of course, if a procedure doesn't meet any of these criteria, it would be in a red category, and we just shouldn't be doing it. So the question is, where does intra-atrial shunt fit? So we've already seen this picture on several prior talks, and I'll talk a little bit more about some of the technical aspects. But for the most part, these are fairly straightforward procedures. They all have in common a transeptal puncture, which for me, any procedure that involves a transeptal is fun. If you can throw a snare in there, it makes it even more fun, but there's no snares involved in here unless you get into trouble. Imaging, also, you can do it with transesophageal echocardiography, but of course, there's now a growing interest in using ICE for such procedures. It's completely venous, also making it low stress for us because it's unlikely you're going to get into a major vascular complication. The catheters are sizable, 14 to 16 French, but certainly well within the range of venous procedures that we do safely. Of course, you can do it under general anesthesia, but you can also do it under IVCS. So it's a relatively straightforward procedure. And I'm going to talk a little bit about the devices that are out there, or at least in the pipeline. This is a device that's been studied the most, the Corvia device called the intra-atrial shunt device 2. And you can see on the left, it's a it's a nitinol structure that will be deployed into the intraatrial septum that gives you a fenestration that's about 8 millimeters diameter. And this is a device that has the most clinical data to date. There was an early feasibility study published in Lancet, 68 patients, which showed that the device is very safe and that the majority of patients did experience a decrease in pulmonary capillary wedge pressure with exercise and rest, at rest and exercise. And then the first randomized sort of feasibility study of 44 patients randomized to device versus a sham procedure, which I do think is important in these type of trials to understand the potential of a placebo effect. And this also showed a significant reduction in exercise wedge pressure in device patients. But the largest trial we have in this particular space now is reduced heart failure LAP2, which just came out this year in Lancet. So this is 620 patients randomized to device versus sham. And the primary endpoint included death and stroke, which are, I think, tough endpoints to potentially prove a benefit in a device like this, but also included heart failure hospitalizations and change in KCCQ scores. And the bottom line is that there was really no difference in any component of the primary endpoint, and there were certain patient subsets where there was a signal of worse outcomes. So patients who had elevation of pulmonary artery pressures greater to 70 with 20 watts of exercise, elevated RA volume index, and for whatever reason, men seem to not do as well. This device, the V-Wave Shunt, is a sort of a three-dimensional bow tie-shaped device that's a nitinol frame with a fabric around it. And the first generation of this device actually had a valve implanted within it. The first in-man evaluation was 38 patients with HFrEF and HFpEF, and showed improvements in 3 months and 12 months in New York Heart Association class, quality of life, and 6-minute walk. But there were some concerns regarding patency. About 14% of patients showed an occlusion of the central orifice at 12 months. 36% of patients actually developed valve stenosis. As I mentioned, the newer device now no longer has a valve as a part of the central mechanism. There's an ongoing randomized trial, Relieve-HF, that will further elucidate the potential value of this device in this condition. And then that is interesting. That is not the picture that I put in my slide, so I'm not exactly sure how that got in there. But this is supposed to be a picture of the Oculotech device, but that is not the Oculotech device. But this is basically a nitinol disc that can be placed within the intraatrial septum, again, leading to a fenestration. You can have several sizes, 6, 8, and 10 millimeters. Again, single-arm studies showed device safety, and there is an ongoing phase 2 study that is going to also look at this particular device in HFrEF patients. Now, one thing about these 3 previous devices that all have in common, they do involve leaving a device in the intraatrial septum. And one of the limitations of that is the inability to potentially close that fenestration if you need to for whatever reason down the line, or if the patient needs a left atrial procedure somewhere else in their lifetime, the presence of a device there may make that more challenging. So more later devices now are looking at ways of creating a fenestration without actually leaving a device behind. So this is the Alleviant Shunt, the AVL1 device. So this is a catheter is delivered across the intraatrial septum, and it uses RF energy to essentially core out a 7-millimeter piece of tissue from the intraatrial septum. So no device is left behind. If you had to go back and close this defect, you can easily do it. The Alleviate Heart Failure 1 study was just a single-arm, 10-patient study. Again, showed very good safety, improvements in New York Heart Association class, 6-minute walk, KCCQ, wedge pressure, and NT-proBNP, and there was actually good shunt patency and size preserved at 6-month TEE. And then the Alleviate Heart Failure 2 trial, again, single arm, 33 patients showing very similar results, and they are in the process of getting their pivotal trial off the ground. This is the Noya device from Denova, which is, again, a device that's designed to not leave anything behind, but it creates a defect, not by cutting, but using RF to expand the defect and create sort of a rounded edge defect at the end of the procedure. So again, no device left behind, no tissues actually removed. again, easily closed, and they've completed their first in-man studies. And then finally, the InterShunt device, which does involve direct removal of tissue without RF energy. It literally just cuts it out. At this point, no human data to date. So where do we need to go with intra-atrial shunting? So first of all, these devices do appear to be very safe and technically very reasonable to do. Talking to people who have done them, you can probably do this procedure in less than 15 to 20 minutes with very low risk. And despite proof of concept, at least with hemodynamics, we've yet to necessarily demonstrate a true benefit to patients in terms of some of the important endpoints that we think about. Whether or not we need to think about potential device or procedural modifications, I think one thing that I personally don't completely understand is how do we decide what the right size defect we need to create? I don't think one size fits all is necessarily the right answer. So I think we need to learn about that. I think certainly leaving no device behind is attractive. And whether or not we can think about a device or a solution that can be modified down the line, we've talked about other devices today where we can sort of cinch, and there are valvular devices where you can uncinch over time, and whether or not there's some way to think about doing that for this particular condition may be interesting. And then future clinical trial design, I think the issue, as we've heard about throughout these talks today, is where is the sweet spot of patients that stand to benefit? Because it makes sense that if we can show decrements in wedge pressure with exercise, we should be able to make patients feel better. And the question is, who is that patient population? We may not have found it yet. And then I think looking at the primary endpoints of clinical trials, I wonder how much we're going to see a benefit in mortality and stroke, for instance, in a procedure like this. It doesn't make sense to me in a short-term clinical trial, particularly for a device that's very safe and easy to do with hopefully very little harm to patients, that we need to be so stringent about showing that we're making patients live longer. I think what's really going to be important for these patients is certainly keeping them out of the hospital and improving their quality of life. And maybe we need to think about different endpoints in the future. So I'll conclude with the following. Patients with HFrEF and HFpEF, I think, are the most difficult to manage. Our interventional options are limited, short of treating their valve or coronary disease. And I will say as an interventionalist that I'm thankful that I don't have a large patient population with HFpEF, and I have my heart failure colleagues to take care of these patients, because these patients live with one wedge pressure, and if it goes a little bit too up, they go into heart failure. If it's too low, they start feeling lightheaded and dizzy. I'm glad I don't have to take care of that. However, it would be great if there was something that I could do to help these patients. Unfortunately, at this point, I think it's safe to say that intra-atrial shunting lacks definitive data for patient benefit, and the key will be identifying patient population that stands to benefit. But I think being able to offer this therapy with demonstrable benefit to patients with HFpEF will, in my opinion, render this an ideal interventional procedure. Thank you very much.
Thank you for your great summary of an exciting area in the field. I agree with you that I think we're unlikely to see a mortality benefit in these types of devices, but it's really the quality of life and the exercise capacity that these patients are looking for. So physiologically, it's a really appealing concept, and one of the ideas that's been put out there is that it's largely a patient selection issue, and how do you pick the right patients, and often, should it be based on exercise hemodynamics or some echo parameter? So I think I'm glad that people are still studying this, because HFpEF can be incredibly frustrating to manage, as I'm sure I don't need to tell anyone in the room. So we have time for one question. Fantastic, in the front row.
After this procedure, what happens to right ventricle and liver in the patient long term?
What happens to, I'm sorry?
RV and liver.
RV and liver.
RV and liver? I personally have no experience with that. I mean, I would imagine that the amount of shunting that we're seeing here ideally is not so much that we're going to be putting the RV under stress. Obviously, that's something we'd have to follow long term. But, I think there's a lot of experience with intra-atrial shunting in a variety of conditions, both in the congenital heart disease space and... Yeah, exactly. And I'm not aware of a particular concern of long-term concerns in those areas.
Yeah. Oh, sure. I'll let Paul respond, and then a question in the back. Yeah, for those of you that didn't hear, the QPQS is typically 1-1-1-2, so it's pretty minimal. So we would expect it would be very modest effect, if any.
How about what happens if
For those of you that may not have heard, Dr. Sriraja added that we haven't seen a lot of decompensated RV failure, and the right side probably has enough capacity to tolerate this volume load. And last question?
It was actually a kind of a response to that.
Oh, great.
The core via data, early going, they did show that there was a little bit of increase in RV size, but also increase in RV ejection fraction. So you didn't actually see more clinical heart failure. The selection criteria for the patients for these studies is very strict on any sort of RV enlargement before you do the procedure. So they have pretty pristine RVs, and so the exclusion criteria for selecting patients for these studies is actually quite strict in terms of the, or it already was, and it'll probably get stricter in terms of pulmonary hypertension, lung disease, and RV failure. The QPQS does tend to sit around 1.2 when you do it. The size is based on a Dan Murkoff mathematical modeling paper that said that between 0.5 and 1 of a shunt, you get all your benefit. So people have been going middle of the road for now at about 0.7 or 0.8. But the point is that I've done patients that, my first patient was a 92-year-old lady who was 4'11". My last patient was a 6'2" German gentleman. They probably don't need the same size shunt. And so determining what the right size shunt for body surface area or where they're at in the evolution of their heart failure, I think is really going to be the challenge down the road. But what we need is a clinical proof of concept. We have physiologic proof of concept, but we need to show some patient benefit.
All right, fantastic. Well, wonderful session. I really appreciate the chance to participate and hope you all enjoy the rest of your day.